Hi there, my name is Kelly Norfolk. I'm going to start this video by weighing this patient. This dog, her name is Callie. She's coming in for spay. She's 7 months old. So this is typically where we usually anesthetize our patients. We do it in a separate area. That way we can get her shaved up and everything before moving her to the surgery suite. Callie has already had her pre-med. She was a little wild, so we had to give her her pre-med before we do her catheter. So right now I'm grabbing endotracheal tubes to figure out which one's going to work best for her once we have her anesthetized. So I'm just measuring along her nose. I believe I put in a 7.5. So first I'm going to inflate them and just make sure that they stay inflated, that there's no leaks. So I'll inflate them and leave them there for 30 seconds to a minute or so, just to give them time if there is a leakage that we can actually observe it. Now I'm measuring the tube to see exactly how far I need to go in. So we're measuring the end of the tracheal tube to her thoracic inlet all the way to the tip of her nose. I was pretty sure that we were going to use that 7.5, so I only measured that one. Now we're going to go ahead and get started by putting that IV catheter in. So I'm just cleansing the area with Chlorohex scrub and alcohol. So I'm going to be using a 22 gauge catheter. Probably could have gotten a 20 in there. In my clinic, we usually stick with this 22. The tape kept getting stuck on my gloves. This is just some flush just to make sure that catheter is patent. We're just going to put a little bit of vet wrap on there just to keep that catheter secure when the dog wakes up from anesthesia. Although she will have an e-collar on when she wakes up. So looks like I left my tubes there for a little bit longer than anticipated, but it's okay. They looked good, no leakage. So I'm going to go ahead and deflate them. One thing that I forgot is we're not using this machine. This is just where, or we're not going to be using the IV fluids over here. This is just where we're going to be inducing. It would be ideal to have her on fluids while we're doing the induction. However, for this patient, my doctor did not feel necessary, so she asked me not to do that. I was actually just reviewing the rate of fluids that needed to be done because initially when this dog was weighed, she was weighed in at 33 pounds when really she was 38. So some of the calculations were actually done before we had that reevaluated weight. That's when I realized we're not using these fluids. So we're going to go ahead and start to induce her. I'm going to flush the catheter, make sure we're still patent. And this is where we have the ketamine Valium, which I will give slowly until effect. Which typically for ketamine Valium, it's usually the whole thing. On rare occasions, is it less than what you pull up? We did have some propofol set aside just in case because this dog was a little high strung, so we weren't sure if we were going to need a little bit more than needed. But she goes down just well, just as anticipated. Go ahead and flush it, just make sure we still have it, or we get the rest of it in there. Rest of it into the dog. This is the laryngoscope that we have nearby the anesthesia machine. It seems to be the go-to. Sam's going to help hold her mouth open for me, and she's going to grab the tongue just to make it easier with that laryngoscope. I'm using my overhead light and my laryngoscope just to make sure I have enough light to see exactly what I'm doing down there and placing the tube. Making sure I measure it to the right, or push it into the right measurement, and then we're going to tie around the nose. So I'm just using an old IV line to tie around the nose. So I'm going to go ahead and turn on my anesthesia machine. We're going to 5. Or actually, I think we started at 3. And then putting her up to 5 because she started to swallow. So while Sam gives a good breath, I'm going to listen to see if we need to inflate that cuff, which we do. We inflate it all the way. I'm going to go ahead and lubricate her eyes. Since she's unable to blink while she's under anesthesia, we would need to keep her eyes nice and lubricated. Just listening, making sure her heart sounds good. Her heart rate was still a little pretty high, so we left her ISO up on 5 for quite some time, just until she started to relax a little bit more, and she did have a blink reflex. I'm going to give her a few breaths here and there just so she gets that anesthesia. Usually when prepping the patient, one person clips nails, one person shaves belly, or shaves the area that we're going to be doing surgery on. So as I'm clipping, I'm just monitoring, making sure that she's, still breathing well. Heart rate sounds good. Obviously, you can see her tongue moving, so she's still pretty with us. Not ready to be turned down just yet. Couple more breaths. She's not there yet. Still blinking. I'm just seeing if she has a reflex on her feet, which I didn't really feel one, but she's still blinking and her tongue was still moving a little bit. She's getting there. And we're doing much better. So we're going to go ahead and turn her down, put her on 3, because we are about to move her into our surgical suite. So I don't want to turn her down too low because she might wake up while we're carrying her over. Nice, good, strong heartbeat. No murmurs heard. Just making sure she's taking good breaths on her own. It's important to get some numbers written down so you have your log. When I first started, I just wanted to make sure our patient was okay and we were getting everything done that we needed to. And now that we're at a stable position, I'm going to go ahead and write down some numbers. Numbers meaning heart rate, respiration rate. At this point, we don't have her hooked up to an CO2 monitor, which she will be when she goes into anesthesia or into the anesthesia room. Sam's gonna vacuum up her belly and get all that excess hair off. I'm gonna give her a few good breaths just to make sure we're nice and deep because we're getting ready to move her. I'm checking to see if we have a bladder and make sure we get her bladder nice and expressed. When my doctor's doing the surgery, the bladder may be in the way, so we want to make sure that she's empty. She actually didn't have a bladder, so I palpated for a little bit longer than anticipated just because I could not find it. And I have Sam just double check to make sure it's not just me, but she does not have a bladder. She had urinated before we put her under anesthesia. Okay, so we're getting ready to move her into our surgical suite. I detached her tube, turned off the anesthesia machine, and now we're going to carry her carefully into our surgical suite. That is a heated table, so I have it on. I already went ahead and prepped it. We already had several surgeries that morning, so we already leak test both machines. However, I did not come back in and change the bag to this patient's size. So we still had I believe that was a 6-liter on from the hound dog that we had earlier. So I very quickly noticed that and went ahead and put a new bag on there that would match this patient's size. And we work together. Sam's putting clips on while I'm trying to tie her up to the table and listen to her. Making sure she's still breathing well. Heart rate sounds good. So also, I'm going to make sure that this patient stays warm. We do not want her temperature dropping. We do not want her to become hyperthemic. Sorry, hypothemic. I'm using alcohol to spray on the clips just so they have nice contact, but I'm not trying to spray too much because I don't want to cool the patient down. We want to make sure she stays nice and warm. I'm just listening and keeping tabs on her. I'm just trying to get everything set up. The monitor's not completely ready yet. I had her isoflurane on 3. Which she seemed to be doing okay on, but then she did start to fight us, so we had to turn her up a little bit here in just a second. And while Sam's still prepping her up, I'm going to start her fluids. I'm covering up all parts of the patient that are not going to be in the way of surgery. That way we can keep her nice and warm and tuck her feet in. Sam's going to scrub while I make sure she's still anesthetically appropriate. Make sure that heart rate starts to come down a little bit because she was a little high, just because she was still awake. We're still just monitoring, scrubbing, waiting for the doctor to come in. Making sure her color looks good and her CRT is below 2 seconds. Make sure to give a breath every 10 or 5 minutes or so. So once we have her stabilized, we're going to monitor her, or I'm going to monitor her every 5 minutes. I'm going to listen, make sure everything matches the monitor appropriately, watch her breaths, make sure she has a nice respiratory rate. We want to keep her heart rate between 60 and 150. She was pretty high with her heart rate. And Sam's just double checking me just to make sure everything looks okay. And here I am with some masks and hair nets. The doctor's getting ready to start. She's going to cut her drape. So we want to make sure that she's anesthetically deep enough for that first cut. Once the doctor starts cutting on her, her heart rate may go up a little bit. So I do need to be prepared to turn that isoflurane up and get her a little bit deeper if we need to. No. My dog wants inside. So we were having a little bit of difficulty with this machine. My CO2 was not appropriate. I asked my mentors what to do at this point because it was not functioning properly. We repositioned the tube at one point. We checked the line. We've done everything, and it just would not function. It wasn't even giving us a reading. So I'm wondering if the line was too moist from previous surgeries, or if the machine just there's something wrong with it. So I kept giving her breaths just to make sure, because I wasn't sure of her end tidal at that time. Another thing was the blood pressure cuff was not functioning properly. It was giving me a really strange low reading, which honestly I wasn't believing, because the trend wasn't accurate, or it wasn't the same. I mean, it wasn't a very good trend. It just looked funky to me. So she's making her first cut. I need to be aware of what's going on, making sure we need to turn that ISO up if need be. The dog seems to be pretty good, pretty under. So I ran to go get the Doppler, so I can read the blood pressure manually, because our machine was being silly. So I have other options for that. I just had to gather my supplies. It's not every day that we use that, so I didn't have it prepared, to be honest. But we do have it close by, so I can grab it pretty quickly. So here I'm just putting the manual blood pressure cuff on, giving her breaths. This is multitasking. This is making sure we are still anesthetically appropriate while trying to get another machine ready. So it takes a lot of focus. So Brenda is actually just switching out the machines for me, because this machine is being wonky and I do not trust it. So she grabbed another machine that we have in another one of our suites. Thankfully, we have multiple machines. If we didn't, then we would need to figure out what was going on. And if we never got a reading for that in title, I would just keep giving breaths just to make sure that we have good expiration. My doctor just keeps rolling as we go. She's staying pretty down. She's not trying to jump off the table, which is good. It's a little bit of a moment of panic just because we don't have a machine on her at this point. But we were keeping close eye on her. So one thing I didn't realize, I was trying to get her blood pressure, and for some reason I couldn't hear it on the Doppler. And so I kept trying and trying, and then I realized her leg is still tied, and because her leg is tied, I'm not getting that pressure that I should. So once I realized that, I untied it, and then I heard her heartbeat right away. which I have confirmed that her blood pressure is a little bit lower than we want. It was hanging around the 70s and 80s. We usually don't want it to drop any lower than 90. So at that point, I told my doctor, hey, this is real. We need to do something. Typically, you'd turn the isoflurane down and potentially bump up her fluids. I just went ahead and asked the doctor what she wanted me to do. And she told me to increase fluids. So she told me the rate she wanted to go. And I believe Sam increased fluids while I wrote down the numbers that I was getting for that blood pressure. The reason I'm not decreasing her isoflurane is because her heart rate was high, and I was a little worried that she would jump up, and so was my doctor. So we wanted to keep her on the same rate or the same percentage and just increase fluids a little bit to get that blood pressure up. At that point, I did turn her down just a little bit because we've gotten to a point where I don't think the surgery is as painful, so we can turn her down a little bit and wait to see if she shows any signs of pain or waking up, which would be blinking, swallowing, heart rate increase, respiration increase. Sam's just adjusting her probes. Because of this change in machines, we were still fiddling with that. So she's just making sure we have the correct probes on. They're just helping me replace this machine while I just monitor her manually. I'm checking her peripheral pulses just to make sure everything feels good because of that blood pressure decrease. If her peripheral pulses were low or weak, then we would be a little bit more concerned. Thankfully, she had really nice, strong peripheral pulses. Sam was feeling too. Her colors still look beautiful. She stayed nice and pink during the whole procedure. Her CRT was 1 second or even less than that, which was beautiful. She had nice perfusion. I'm just checking another blood pressure just to see where we stand. Thankfully, I had Sam and Brenda helping with that machine. If they weren't there and it was just me monitoring anesthesia, I would have to multitask and just get that machine hooked up, or just forget it while I'm doing manual monitoring. So we're getting a better result, so those fluids must be helping. Also, the decrease in isoflurane probably helped her too. I finally started getting an end tidal CO2 number, which was normal. Thankfully, it was under 55. 55 would be a little bit concerning, but being that she's a little bit anesthetically difficult, I wasn't too concerned at that point. Her respirations were great. She was breathing on her own, thankfully. I didn't have to bag her too much. It is still important to bag her every 5 minutes or so just to make sure she gets that really good breath and gets all of her EVLI expanded. So we try the monitor again. So we're trying to hook up the monitor blood pressure to see if we're getting an actual reading or something that we can actually believe going along with her trend. She still looks really nice and pink. So when I'm doing the bagging, I'm actually holding off the pop-off valve and giving her a nice breath up to usually about 15 on the pressure on the manometer. You don't want to go any higher than 20 because this patient was just a little bit smaller than average. I did about 15. Another way to look is, or another way to tell how much pressure to give is to actually look at the patient when you're giving that breath and see how well she expands. I was definitely happier with this monitor. It was giving me much better readings. Blood pressure was still on the low side, but definitely improving with the fluids. So finally, now that we have the machine going, doing all the monitoring, I can stand back just a little bit more and relax. Dr. Hoffman actually asked me to check another blood pressure just to see how we compare. I'm still watching very carefully, making sure she's taking good breaths. Making sure to document every number that I get. If you look at my anesthesia sheet, there are some missing numbers on there, and that's because we were having such trouble with the machine. The end title was not showing up, neither was the blood pressure at the beginning. So there are some blank areas, but you know, you can only do as good as you can. I was really happy with the respiration rate. She was doing so well with that. Her gums were so nice and pink. Her perfusion was beautiful. The surgery itself was going really well. There was no excess bleeding or anything that we could have gotten into. Heart rate was definitely maintaining. We kept her on 2% for a little while on the isoflurane. She seemed to be stabilized really well on that. I could have tried to go a little bit lower just to see how she does, but with everything going on, I just wanted to keep her pretty stabilized and not mess with anything. I think once we get a little bit closer to the end, I turn her down to 1.5. Just because it's, we're starting to wake her up, so we want to wean her off a little bit here and there. Sam's wetting those probes just to make sure they stay nice and moist because of all the change that we've had. It's important when you're going underneath the drape to make sure you don't hit the doctor's actual incision site or knock anything over. You have to be really mindful of what you're doing and where you're putting your hands. I'm still just keeping tabs on her color, make sure she's nice and pink. Like I said, we didn't have any excess bleeding, so if we did, I would definitely keep an eye on her gums and make sure we're not getting pale or losing that color. Now, we were getting pretty good readings on the machine, but Dr. Hoffman just wanted me to make sure with this Doppler, because we were having some issues, that everything was correct. One thing I did notice is her blood pressure did decrease a little bit at one point. I let my doctor know where we were standing, and she said probably once we get her off of isoflurane, that'll come back up. So once we get her out of anesthesia and get her into a recovery room, we want to make sure that we keep tabs on that blood pressure, and if it does not go up, then we need to address it. Another thing that I asked the doctor at one point was to see if we needed to decrease the fluid since we upped them earlier. She said just to leave it. It's not going to hurt anything to keep them on at this point. She has a really nice, strong heart rate, no murmur that we've heard. And because that blood pressure was a little bit wonky, we want to keep those fluids up. So the doctor gave the okay to go ahead and start turning things off because she's done with surgery. So the first thing we do is turn off isoflurane, which was on the other side of the table. So I just asked Sam if she could turn it off for me, which she did. So now we just have some oxygen flowing into her. We typically want to leave them on oxygen for about 5 minutes after anesthesia, just to help oxygenate them, make sure that they're breathing well. So I gave her breath, and then I also just got rid of all that anesthetic gas that's inside that bag. So the only thing that she's getting is that oxygen. We don't want any leftover isoflurane in the bag or in the machine to keeping her down. Just keeping tabs on that blood pressure. Making sure that we're staying up, which once we turned off this isoflurane, her blood pressure did go up quite a bit, back to normal. So we were really happy with that. So Sam is actually disconnecting her IV fluids because we're getting ready to move her into her recovery room. So one thing that the doctor asked was to just keep tabs on that blood pressure, and if we need to have the IV fluids running in the actual recovery room, we need to move everything. Fortunately, because once we turned her off isoflurane, her blood pressure went back up to normal. We did not have to do IV fluids, but that would be something that you could do. So I'm just going to try and clean up this area, make sure I get everything out of the way, make sure she's still anesthetic appropriate while we're cleaning her, making sure she doesn't swallow or bite the tube or anything because she is off anesthetic gas. I'm just untying her legs, making sure she is ready to move. One thing you don't want to do is move her while that tube is still connected. If you do move her, it can cause esophageal tears. So it is so important if you move the dog at any position, you need to detach the line from her tracheal tube. So I went ahead and moved her on her side a little bit because we just want to get her in lateral recumbency. Make sure we get her nice and cleaned up. And I just went ahead and attached her again to the oxygen. Once I had everything untied, it's not going to hurt to give her a little bit more oxygen. So let's keep it flowing. I figured by the way her heart rate was during anesthesia that she was going to bounce up pretty quickly. So I made sure that everything was untied. I want to make sure the cuff was completely deflated. That way that tube is ready to come out once she starts to swallow. We do not want her to bite on the tube and have pieces fall off and potentially aspirate it. We're still trying to keep her nice and warm. Sam's actually taking her temperature at the moment, and she was about 99 post-op, so that's beautiful. That's where we want them to be. If she were lower, we would definitely get some warming devices on her while she's in recovery. Because she was at such a good temperature, we just went ahead and kept her with some blankets. She didn't need a heating pad, or sometimes we'll fill up or we'll microwave IV bags and call them warmies, and we would put some warmies on her just to keep that temperature up. So we're ready to move. I'm going to go ahead and detach her from the oxygen, make sure I turn it off, turn everything off before you walk away, where you don't waste anything or get anything in the air that you would breathe in. So we had a recovery cage already set up for her in our dog ward. So it's so important to keep her warm. Some people in my clinic keep them in lateral recumbency when they're recovering. I think it's better just to have them on, have them sternal. They breathe easier. And if they have any excess mucus or anything in their esophagus, they can shoot that out easier. So now we just monitor and make sure she wakes up appropriately. So I'm looking for any signs of movement. So her respiration rate, her her blink reflex, her swallowing reflex. I kind of bug her a little bit by pulling on her tongue, petting her, but softly. I want to pet her softly and just kind of talk to her just to get her up. Dr. Hoffman wanted me to check one more time that blood pressure just to make sure. And this is where I find out that she is just beautiful. She's where you want her to be. She's actually, I believe we got her above 130. I don't have the paper in front of me at the moment, but we got her up way higher than she was during anesthesia. And I could see that her eyes were opening a little bit more. She started to breathe heavier, which is great. We want her respiration rate to come up a little bit. Silly dogs. Her blood pressure is great. Here I am just rubbing her nice and softly, trying to bug her to get her to wake up. She didn't pop up like I thought she would. Now, if she had propofol instead of the Ket Valium, she probably would have been up a little bit sooner. But this Ket Val is good stuff. Keeps them down a little bit easier. I like using it way more than propofol. So what I'm waiting for, she needs to swallow 2 times on her own, so I know that she still has a gag, or she gains her gag reflex back. That way she doesn't aspirate or in case she vomits. We don't want her to aspirate. I was looking at her incision just to make sure we didn't have any excess bleeding, swelling, redness, anything like that, and it just looked great. I want to stay with her until she is awake. Sometimes when you're trying to wake them up, they do hold their breath. So petting and stimulating is a great idea just to get them to get up. She does not need any injections or anything right now. Later on, when she is awake, we noticed that she was salivating a little bit more than usual, so we went ahead and gave her some Serenia because we thought she was nauseous, but no antibiotics are necessary. I was moving the tube just a little bit just to see if we could get that gag reflex stimulated. Moving her tongue, rubbing her throat. She was just being difficult. She was definitely showing signs of waking up, but she just wasn't there completely. There, she pulled away from me. But still, she hasn't swallowed. And she has swallowed 2 times. And she even swallowed after I pulled the tube out, which was great. I'm still stimulating her, making sure she takes a good breath. And that's it. Thank you.